Thus, the frequent monitoring is associated with lower risk of progression, longer progression-free survival, increased treatment adherence, few inpatient hospital visits, and reduced financial burden as per the Western data. So, as I mentioned that as the world is moving towards the TFR, different studies have listed the benchmarks of DMR that can be expected by 5 and 10 years. And now the current guidelines have set established criteria which can be foreseen for the patients who are a candidate for TFR. An attempt at treatment discontinuation can be considered if sustained DMR of sufficiently long duration has been achieved. Before moving towards the challenges in the treatment of chronic myeloid leukemia, I would like you to have a look at the literature published by Pakistan. This study was the first study published in 2009 by the Shaukat Khanum Memorial Cancer Center. They basically reviewed 461 CML patients, and they reviewed the demographics data of these patients, that is the study of the pre-imatinib era, and they concluded that the median age was much younger in Pakistani population as compared to the West, and they have a quicker progression of disease. And they anticipated that the advent of TKIs are likely to have more impact on the lifespan of CML patients in Pakistan when compared to the Western data, as we have younger age at diagnosis. Another study was published in 2012. This was also done on the Pakistani population, and this basically analyzed the clinical and hematological features of 335 patients diagnosed at one of the major referral institute of northern Pakistan. They concluded that in contrast to the Caucasian population, once again, the peak incidence, the population in Pakistan is much younger, and they also discussed some of the challenges that in their part of the world, patients presented in fairly advanced disease because of poor access to the healthcare facilities, delayed presentation, non-affordability, and lack of health insurance coverage. This is another study which was published in 2015, again by Shaukat Khanum Cancer Center. They basically analyzed the characteristics outcome of patients with blast crisis CML. And this is the study of post-TKIs era, where they concluded that survival is now increased with addition of TKIs and its conversion to the blast crisis. Basically, the patients when present in the blast crisis, they are less responsive to treatment and have high mortality. They analyzed the total of 240 patients, and in detail, they reviewed the clinical records of 20 patients who were transformed into blast crisis during the disease phase. And out of those, 8 patients were they transformed into ALL, and 12 patients transformed into AML. And these patients, in conclusion, they concluded that the blast crisis remain a challenge, particularly in under-resourced area where allogenic stem cell transplant facilities is sparse. This is the data of 2015. Things have changed now. However, they concluded that outcomes remain dismal in majority of the patients who presents with blast crisis in their part of the world. This is another study which was published by NIBD in 2019. This study basically reviewed the efficacy and safety data for nilotinib in our part of the world, as the data regarding nilotinib in Asian population is scarce. They basically reviewed a total of 173 patients who were newly diagnosed CML in chronic phase. Majority of the patients have high so-called risk score, and they basically analyzed the cumulative incidence of MMR and DMR, which was found to be 86%, and DMR was found to be 39%. So they also found out that early MMR and DMR at 6 months were achieved by significant number of patients in their cohort. So this study showed that promising results are achieved in terms of achievement of early and sustained DMR in those patients who presented in CML chronic phase. Therefore, nilotinib can be considered as frontline treatment in our part of the world. This is one of the another study which was published by our colleagues, Pakistani colleagues. This study was conducted basically in 2018 and 9 on 198 CML patients. And their results showed that when the patients were started on first-line TKI, that is imatinib, and they were after the regular treatment of 2 years, majority of the patient, there was significant number of patients who showed DMR. And majority of the patients, they show significant cytogenetic response at the start of treatment as well. So the compliance is very, very important. Another study was published in 2022 by Professor Zeba Aziz and colleagues. This basically analyzed the treatment challenges in access to the new therapeutic agents in Pakistan. This was one of the very big study, constituting a cross-sectional survey of 28 public and private sectors. This focused on 3 oncological domains, that was breast cancer, DLBCL, and CML. They basically tried to analyze the cancer care disparities which persist among the medically underserved patients of cancer in Pakistan. And they also studied and reviewed the implications of those barriers to the effectiveness of treatment, ways to overcome those barriers with particular attention to these cancers. And surprisingly, they also reviewed that in CML, the compliance to imatinib and nilotinib was quite significant, and that was found to be 85%. The rest of the challenges, they were more encountered in breast cancers and DLBCL. So in conclusion, they concluded the study as significant barriers exist in providing optimal basic and targeted therapies in our part of the world to those patients, despite of government funding and even available access programs. So there are certain other factors as well, in addition to the cost, funding, and access programs that need to be looked. This is one of the another study which was published by Holy Family Hospital, Rawalpindi. They concluded the imatinib resistance in CML patients and associated with age and gender. However, there are a lot of shortcomings or limitations of the study because they studied the complete hematological response only. This study did not review the major molecular responses. However, they concluded that imatinib resistance in their cohort is quite common while treating the patients with chronic phase. And there's a significant association with different age groups. However, non-significant association was gender in terms of response was noted. This recent study is published by Armed Force Institute of AFBMTC, Pakistan. And they basically analyze the outcomes of allogenic stem cell transplant and chronic myeloid leukemia. It's a single-center experience where they retrospectively analyzed the data of 73 patients. In total, they included 73 patients, and data was analyzed from 53 patients. And they found out that a median follow-up of 40 months, overall survival was 72%, which is quite promising as compared to the previous literature that we reviewed so far. Survival in patients is less than 40% was much better as compared to those patients who are aged greater than 40 years. Among the 3 conditioning regimes they used, they found out that BuSci was the most commonly used and had a better overall survival. So they concluded that in addition to the established indication of resistance or intolerance to the TKI for bone marrow transplant, the non-availability, affordability, young age, and lack of access to the novel drugs can be included in underdeveloped countries like Pakistan. So in review of the data that has been published in Pakistan and our part of the experience, the challenges that we found in our patients is main lack of finances. Health is not funded in general. Most of the times we have drug interruptions in access programs as well. The patients are not well aware, lack of literacy. The patients usually found CML to be asymptomatic and they present late to the physicians. And when they present in accelerated phase and blast crisis, things are different. Affordability, molecular monitoring. There are limited centers for assessing the molecular monitoring. Facilities are not available. And even though they're available, the lack of cost hinders the regular monitoring. If we talk about the TFR requires stringent monitoring, which is practically very difficult in our part of the world, difficult to convince, difficult to make patient do molecular monitoring monthly. Access programs are uncertain. The drugs that are available are baggage, lack of efficacy, concerns regarding stability, drug intolerance, lack of literacy, and delayed presentation. So these are some of the challenges that we face in the CML in contrary to the Western world. I would like to finish my talk. Thank you very much. Thank you for your patience. Thank you.
Thank you, Dr. Nida, for an excellent talk, very relevant to our population. So our next speaker is Dr. Firas Al-Kaisi. He'll be talking about new advances in myeloma treatment. He's a consultant clinical hematologist at Royal Derby Hospital, and he's a myeloma lead there as well in UK. So over to Dr. Firas Al-Kaisi.
Hello, my name is Dr. Firas Al-Kaisi. I'm one of the hematology consultants at the Royal Derby Hospital. Thank you very much for the invite to speak at your esteemed meeting. Today, I'm going to talk to you about new advances in multiple myeloma treatment. Now, as we all know that multiple myeloma is the second most common hematological cancer. It is actually a very complex disease. It has a remarkable molecular heterogeneity, and it's perhaps not a single disease. It's perhaps a collection of different disease biologies and different entities that share some common molecular characteristics. We all know that the development of multiple myeloma requires the acquisition of certain primary genetic events. These involve either chromosomal translocations or hyperdiploidies of odd-numbered chromosomes. Now, those changes on their own are not enough to cause plasma cells to turn into malignant myeloma, but the acquisition of secondary genetic events is also very important to this process. And as you can see from the table, there are a number of those genetic events. There has been a significant expansion in myeloma therapies over the years. Multiple myeloma was classically treated with alkylators in the 60s and the 70s. However, there has been a significant improvement in the overall survival with the admission of autologous stem cell transplant for the treatment of myeloma. And further understanding of the disease biology led to the development of further novel therapies, such as proteasome inhibitors, immunomodulatory agents, and more recently, T-cell engagers and chimeric antigen receptor T-cells. This is the current treatment pathway for patients with multiple myeloma in England. The choice of drugs is highly influenced by what is actually funded, and it is also based on the results of clinical trials. At the moment, transplant-eligible patients with multiple myeloma get a quadruplet combination with daratumumab and VTD, to be followed by an autologous stem cell transplant, then lenalidomide maintenance as first line. Carfilzomib or DVD can be used as second line, and then if patients have not had lenalidomide, they can have that in third line. Transplant-ineligible patients, however, can access DRD. This has been recently approved, and somehow the treatment pathways converge after first-line treatment for transplant-eligible and transplant-ineligible patients. Now, other combinations of Velcade are still in use. For example, Velcade with melphalan prednisolone can still be used for patients, especially with severe renal failure, and perhaps without melphalan to try to revert the renal failure quickly. And sometimes we use a combination of VTD with PACE chemotherapy, especially for those myeloma patients with high proliferative disease or those with a plasmablastic morphology. Nevertheless, we know from results of very thorough research that there is a significant attrition rates between different lines of treatment. Our data collection that we presented recently at EHA also confirms this from the local patient population. The median progression-free survival in the first line was significantly higher than subsequent lines of therapy. And as you can see, there's significant attrition rate with subsequent lines of therapy. It's also important to mention that refractory disease reduces overall survival, as you might expect. For example, patients who are triple refractory, this means that patients who've had or refractory to a proteasome inhibitor, an immunomodulatory agent, or an anti-CD38 antibody have an overall survival of 9 months. Those with penta-refractory disease, on the other hand, their overall survival is significantly worse at 5.5 months. Penta-refractory disease means that patients should have had at least 2 proteasome inhibitors, 2 immunomodulatory agents, and at least 1 anti-CD38 antibody. This means that there's a constant need for the development of new therapies, and the development of those therapies is based on thorough understanding of the molecular pathology behind the pathogenesis of myeloma cells. Today, I'm going to talk to you briefly about some of the novel therapies in multiple myeloma. So I'll be talking about CAR T cells, T cell engagers, antibody drug conjugates, venetoclax, modakafusp alpha. I've mentioned melflufen in the list, but I'm not going to talk about that because it didn't perform well in most recent clinical trials. As you know, CAR T cells are engineered T lymphocytes. They have the capacity to recognize an antigen of choice on the target cell. Most commonly, it's a BCMA on the myeloma cells. That's B cell maturation antigen. This antigen is highly specific to plasma cells. Following the recognition of the BCMA, or indeed any other target, the CAR T cells are able to launch an immune attack against the myeloma cells. There are 2 CAR T cells that have been recently approved because they performed really well in clinical trials. First one is cilta-cel, the second one is ide-cel. Cilta-cel has a unique design because it employs double BCMA targeting antibodies. The results of the CARTITUDE-1 clinical trial, which is a phase 1b/2 clinical trial in heavily pretreated patients, showed a very high progression-free survival of 34.9 months with a very good median duration of response. The combination of the comparison between cilta-cel and the standard of care in a randomized fashion was investigated in the CARTITUDE-4 clinical trial. The median PFS of the standard of care was 11.9 months. As you can see, those results are very impressive, especially in those patients who have been heavily pretreated. Patients in the CARTITUDE-1 clinical trial are lenalidomide refractory, and a significant proportion of them is triple refractory. Ide-cel was investigated in the CARMAT clinical trials. CARMA-1 is a single-arm phase 2 clinical trial that showed a median progression-free survival of 8.8 months in the ide-cel arm. The CARMA-3 clinical trial randomized 386 patients to ide-cel versus standard of care. The median progression-free survival was 13.3 months. This appears to be lower than what we've seen with the cilta-cel, but one has to remember that the patient population in the CARMA trials was significantly heavier treated as compared to the CARTITUDE trials. Nevertheless, there are some significant side effects associated with those treatments. CRS is the cytokine release syndrome. Patients can become really unwell because of that and may require admission to the intensive care department. Grade 3 to 4 cytokine release syndrome was not very high in both of those CAR T cells, perhaps related to the better design of those CAR T cells and the use of anti-CRS measures as soon as this is identified. Neurotoxicity is also an important side effect. As you can see, the risk of having grade 3 to 4 neurotoxicity is small with both of those CAR T cells. Moving on to the bispecific T cell engagers, those therapeutics employ a unique design. They recognize an antigen on the myeloma cells, most commonly BCMA again. But what they also do is they recognize CD3 on T cells. And what happens is that because of the antibody binding, the antibody causes the T cells to be in close proximity to the myeloma cells. And the activated T cells cause, obviously, the release of perforins and granzymes, which causes the destruction of the myeloma cells. There are 3 main T cell engagers that have been in use in clinical practice, and indeed they have been recently approved. Teclistamab and elranatamab target BCMA, whereas talquetamab targets GPRC5D. Teclistamab has been investigated in the Majestic clinical trials. Majestic 1 showed a median progression-free survival of 11.3 months and a median duration of response of 18.4 months. This is very impressive, given that the patient population involves a significant number of triple refractory patients. However, one must not forget that those treatments are not without their own side effects. For example, Majestic 1 grade 3 infection risk was 45%. This is really this is significantly high, and it could affect the patient population that we choose for those drugs. The Majestic 3 clinical trial, on the other hand, randomized patients to teclistamab and daratumumab combinations versus the DVD or darapom dex. This is in patients with 1 to 3 prior lines of therapy, and this is still ongoing. Elranatamab has been investigated in the Magnetism clinical trials. Magnetism 1 showed a CR rate of 30% with an overall response rate of 70%. Magnetism 4 is still ongoing, and it is a combination of elranatamab with lenalidomide and dexamethasone. And Magnetism 6 is in the phase 2 of Magnetism 6 is in the planning stage, and it involved moving elranatamab to earlier lines of therapy. So this is going to compare daratumumab, lenalidomide, and dexamethasone versus daratumumab, lenalidomide, and elranatamab. This is going to be in patients who are transplant ineligible. Talquetamab targets a different antigen. It targets GPRC5D. Again, this is very specific to plasma cells. The effect of talquetamab has been investigated in the monumental clinical trials. The triple class refractory response rate was 72%, not very different from the pentaclass refractory patients. And the Monumental 3 clinical trial is a combination of talquetamab and daratumumab with or without pomalidomide versus pomalidomide, daratumumab, and dexamethasone, and this trial is still ongoing. Now, because the target is different, side effects are different as well. There is a higher rate of CRS, but also there's significant skin side effects. This is because GPRC5D can be expressed on epithelial cells. Patients who've had this treatment have had significant skin-related side effects, and nail side effects, also loss of taste as well. Antibody-drug conjugates have been in use for quite a while now. The main drug is belantamab mafodotin, and this is an antibody that is against BCMA that is bound to a tubulin toxin called MMAF. Now, MMAF is very potent, but it's very, very toxic to be given on its own, and therefore it needs to be given in a targeted fashion. After the internalization of the antibody and the MMAF by the myeloma cells, the MMAF will exert its effect on the tubulin inside the myeloma cells, and that causes cell death. Now, belantamab mafodotin was approved after the pivotal phase 2 clinical trial called DREAM2, compared between 2 doses of belantamab. Now, the overall response rate was not very impressive. Only 30% of patients achieved that. However, the patients who actually responded to treatment did really well, and the median progression-free survival was over a year. However, the median progression-free survival for the whole group of patients was not impressive at only 2.8 months. MMAF has a unique side effect. It can affect the cornea, and it can cause keratopathy. This is a significant side effect. As you can see, more than around 3/4 of patients had that side effect, and it is often a cause for treatment delay. Patients on belantamab mafodotin require frequent visits to the ophthalmologist, and depending on the grade of the keratopathy, we can decide whether to continue the treatment, reduce the dose, or indeed stop the treatment and wait for those changes to resolve. Unfortunately, the combination of belantamab and steroid did not stand to the combination of pomalidomide and dexamethasone. The PFS was numerically longer in the belantamab arm, but it was not statistically significant, and therefore belantamab is no longer available in the US or Europe. It's available in the UK on a compassionate basis. Very briefly, venetoclax, as you know, has been used in the treatment of CLL for a very long time. It is a BCL2 inhibitor. Now, most of the myeloma cells are MCL1 dependent for survival, but there is an entity, a small group of myeloma cells, around 20%, who tend to have the T1114 translocation, have higher BCL2 levels, and therefore are more sensitive to venetoclax. Bellini trial was a combination of venetoclax, bortezomib, and dexamethasone against bortezomib and dexamethasone. Now, this trial was for all comers, so they didn't pre-select the T1114 patients. It showed a higher PFS in the venetoclax arm, but the overall survival was worse. This led to the design of the Canova trial, which was recently reported in the IMS 2023. This was a comparison between Pomdex and venetoclax and dexamethasone only in the T1114 patients. Now, again, disappointingly, the primary endpoint of progression-free survival advantage was not met. Finally, modakafusp alpha is it's a novel therapy. It's a first-in-class. It uses interferon alpha that is actually genetically fused to an anti-CD38 antibody. Now, as you know, interferon is an old treatment for multiple myeloma. It can activate the immune cells, and it has an anti-proliferative effect against the myeloma cells. Early phase clinical trials are still underway. Now, as you can see, that there are several exciting developments in the field of multiple myeloma, and those are based on the understanding of the molecular pathology of the disease. However, they do come with major limitations. As you can see, the infectious complications are significant. The risk of CRS and neurological toxicity is important, and the risk there's a cost implication treating those side effects. For example, they do require intensive care, tocilizumab, immunoglobulins to combat infections, and there's also a cost limitation to those drugs. Now, perhaps the use of immunotherapies is better suited at earlier lines of therapy to avoid immune exhaustion, and that's somebody that we are going to see in the next few years with more results from the most recent clinical trials. Thank you very much for listening, and we'll look forward to your questions.
Thank you very much, Dr. Faraz. Our next speaker is Dr. Ghulam Nabi Kakipoto. He's consultant hematologist at Stafford Hospital, Stafford, UK. He'll be talking on mantle cell lymphoma management, trends and novel agents. Where are we going?
Bismillahirrahmanirrahim. Assalamu alaikum. I am Dr. Ghulam Nabi Kakipoto, consultant hematologist currently working in the UK. I am really thankful to the organizers of this Shaukat Khanum annual symposium, especially Dr. Bushra Hassan, who kindly invited me to deliver this talk on mantle cell lymphoma. So what I'm going to do today is, I have nothing to disclose. What I'm going to do today is give a bit of background and diagnosis of mantle cell lymphoma, briefly about investigations, and a little bit more dwell on the treatment. We know that mantle cell lymphoma is not that common. It's about 5 to 7% of all lymphomas in the European and North American registries. The median age is 67 years, and majority are the males. It is biologically quite heterogeneous, but behaves aggressively, leading to the death of the patient. The cell of origin is suggested to be a marginal zone, or peripheral blood be a memory cell. Most patients present with palpable nodes without the symptoms, and approximately a third would have the symptoms at presentations, and many would have bone marrow involvement as well. Sometimes we pick up these small lymphoid cells in the peripheral blood mimicking CLL, and when we do the immunophenotyping, it turns out to be mantle cell lymphoma. About 10% present with extranodal disease either in the gut, lung, or elsewhere. MCL is a name given to the lymphoma which arises from the expanded mantle cells. And morphologically, as I say, that it typically looks like small CL-like cells, and at times they are pleomorphic or blastoid. If we look at the histology of the lymph node, it shows that either it can be a nodular or diffuse pattern, and sometimes just mantle zone or enlarged. Really a follicular pattern. A diagnosis is clinched by doing immunophenotyping either on the peripheral blood flow, using flow cytometry, or on the bone marrow, or immunohistochemistry on the lymph node or bone marrow refine. Typically, this is CD5 positive, 19 positive, and CD20 positive, but negative for CD23. And at times, it's SOX11 positive and FMC7 negative, which is positive in CLL. Similarly, CLL would be positive for CD5 and CD23, but of course, CD10 negative. The hallmark of mantle cell lymphoma remains this 11 to 14 translocation of cytogenetics, where the hemoglobin heavy chain gene is juxtaposed to CC and D1 oncogene. At times, other oncogenes like CCND2 or 3 are mutated or their ATM gains, and some people would have a high risk mutation in TP53. Typically, we would do a baseline investigation, including full blood count, or CBC as it's called in Pakistan, biochemistry, including renal, liver, LDH. Some people would have high LDH, which is one of the prognostic markers. CT scan is done for the staging, and the PET scan would show any higher grade areas which are metabolically active. Bone marrow is many times involved, so bone marrow is important to do. Occasionally, there are GI symptoms or chest symptoms which might require endoscopies and the biopsy. This staging was proposed in the Lugano, which is more or less similar to the Ann Arbor staging, where one side of the low, if just one nodal area is involved, it's stage 1. If there are two, if there is extra lymphatic site, extra nodal site is the 1E. 2 or more nodal areas is 2, and with the E with the extra nodal site. And if on the same side of the diaphragm, if there are both sides of the diaphragm, it is stage 3, and if excessive disease is stage 4. Typically, mantle cell can be divided into 2 categories, like an indolent mantle cell or aggressive. Indolent typically are asymptomatic with a leukemic phase with a low Ki-67, less than 30%, low MEP score. They would have these small cells on peripheral blood film, and they are typically SOX11 negative and no P53 mutation. And in aggressive type, the MCL, they are usually have these symptoms. They have nodal involvement or external nodal involvement, Ki-67 greater than 30%, and high MEP score. I'll come to the MEP score in a minute, and have blastoid cells and SOX11 positive and would have P53 mutation. The MEP score is done to really categorize into different prognostic models, and a simplified MEP score is typically used nowadays, where the age is grouped less than 50, or 50 to 59, 60 to 69, or greater than 70, and also an ECOG performance is put in the equation along with LDH and white cells. So the low risk would have a much better survival, as seen in this chart with the blue line, and intermediate would have a brown orange line, and higher risk would have seen as a green line. Sometimes we add also the biological marker like Ki-67 in the MEP score. So let's get to the treatment. Indolent low volume patients would not require treatment initially, and they can be offered wait and watch policy. Generally, these people would have a splenomegaly, low volume disease, and circulating lymphoma cells, and many times bone marrow involved. And we usually recommend to do the prognostic models in these patients as a diagnosis, like looking at the Ki-67 scoring, which is 50% or more is high risk with either blastoid morphology or pleomorphic morphology, and if there are genomic mutations, particularly P53. People who are asymptomatic, usually, as I said, we offer wait and watch. And if they progress, we would offer BTK inhibitors like ibrutinib. In a high-risk patient or patients who are symptomatic, we look at the age and comorbidities. In a younger fit patient or people who are less than 65, we can offer an alternate cycle of mixed-CHOP with high-dose Araceli as an MCL2 protocol, followed by autograft, or some other regimen followed by autograft. In the elderly fit patients, we could offer chemotherapy like R-CHOP, followed by R maintenance, or R-benomycin, followed by R maintenance. In elderly frail patients, we would offer only rituximab or chlorambucil to ameliorate the symptoms. In an early stage, which is non-bulky, with a low volume disease, involved radiotherapy is sufficient to control disease. they would invariably progress and would go on to require systemic therapy. As I said, in a fit patient who's less than 65, a typical treatment would be an R-CHOP or MCL2 protocol, I'll come in a minute, or R-hyper-CVAD, or R-bendamustine, or R-BAC. Let's move on to that. In Britain, we typically use the MCL2 protocol with alternate cycles of Mexi-CHOP and high-dose RC along with rituximab, followed by autologous stem cell transplant. And it has been clearly shown by the Nordic group that they do fairly well, and about 50% survival is up to 8 to 10 years, which is progression-free survival. Many patients go on to relapse even after many years. If we apply MIPI, the low MIPI do better as compared to high MIPI in both overall survival and progression-free survival. In North America, people have used R-hyper-CVAD or R-bendamustine as the initial first-line therapy, followed by autograft. And in this study, it has been clearly shown that both are equally effective. And the only thing is to point out is higher toxicity with R-hyper-CVAD. This is a graph which actually shows the addition of rituximab to conventional chemotherapy regimens, which was in 2000s, and it clearly shows that rituximab has added much advantage to chemotherapy agents, including in mantle cell and other lymphomas. As I said, a good majority are going to relapse even after autologous transplant, and even relapses occur many years down the line. As I say, the risk factors include high MIPI, blastoid histology, or high K6 or TP53 abnormality. If it's a localized relapse, we could get away with a localized radiotherapy, and mantle cell lymphoma responds very well to radiotherapy. In a young fit patient who have had the autograft and has relapsed or has got a progressive disease, we could offer second-line treatment, as I have said, and I'm coming to that in a minute, which could be BTK inhibitors or other chemotherapy regimens with or without rituximab. And if it's high risk with blastoid morphology or TP53, they should go on to receive allograft if they are a suitable match. Typically in Britain, we have been using RDHAP or GMOX. Nowadays, we have been using R-bendamustine and R-BAC, but many times we also use BTK inhibitors like ibrutinib or acalabrutinib. Only majority of patients would be suitable for allograft, considering the comorbids, age, and performance status and availability of the donor. The salvage therapy, the Italian study shows a comparison between R-bendamustine and R-BAC, which is R-bendamustine and RRC. R-BAC is slightly better as compared to R-bendamustine alone in terms of complete remission and 2-year progression-free survival. But there was more thrombocytopenia in R-BAC group, which is reflected in this graph. In salvage chemotherapy, if you look at the top and the bottom one, these people went on to receive the allograft. The 5-year progression-free survival is between 25 and 35%, with some GVHD and stomatitis. If these people are not fit for allograft or they don't have a suitable donor, then these people can be considered for CAR-T therapy. Now, this is something very new in the last few years. And typically, if such a patient who is not fit for allograft, we would consider holding the disease with agents such as a BTK inhibitor like ibrutinib or acalabrutinib or zanubrutinib, with or without rituximab. And this can hold the disease for many years down the line. And if they relapse, they would be candidates for CAR T therapy. There is essentially no age bar currently on CAR T therapy. In one recent study, it has been shown that people who relapse after having a BTK inhibitor, polatuzumab, rituximab, and bendamustine was used successfully to downgrade the disease, followed by CAR T. And this PET scan clearly shows that in the B cartoon, you see the disease at the time of starting polatuzumab with RB, and in the middle, in the C, it shows complete metabolic remission with polatuzumab RB, and the D is after having CAR T therapy. Now, what is CAR T? Actually, it's the patient's T cells are harvested and they are inserted a gene which then shows up as an antibody on the surface for CD19 antigen, and it binds to the CD19 antigen on cancer cells, and the T cell gets activated, and it causes the cytokines to be released, and that's how it kills the tumor cells. These cells are homed considering they are patient's own cells, so they are not rejected. And in the recent ZUMA-1 trial, which was done in diffuse large B-cell lymphoma, it has been found to be very successful. And in the ZUMA-2 trial, a cohort of mantle cell lymphoma was involved, and 60 patients who were intention to treat were analyzed with an overall response rate of 93%, which is fairly good, and a complete remission of 67%, and many are still in remission. Considering that is a very high-tech treatment and very expensive, the availability is limited, and as far as I understand, it is not available in Pakistan at the moment. It certainly carries some major side effects, including CRS cytokine release syndrome, and as well as quite serious ICANS, which is a neurotoxicity syndrome, and it carries quite high morbidity and mortality. In Britain, we, as we diagnose the patients with mantle cell lymphoma, we would do the MEP scores and other analysis such as P53, and then tailor the treatment accordingly, and design the patient for future allograft or CAR T once they have relapsed after the autograft or after first-line treatment. If patients cannot have the CAR T, then we can hold the disease with a number of agents like BTK inhibitors, like ibrutinib, acalabrutinib, zanubrutinib, or pirtobrutinib. And these all agents are available in the UK. And people have been using a lot of other agents, including lenalidomide, bortezomib, temsirolimus, idelalisib, or BCL2 inhibitors like venetoclax. I'll just briefly mention about ibrutinib and other BTK inhibitors. Ibrutinib has a very good response rates, up to 60% overall response rate and 50% complete remissions, and progression-free survival of 27 months. Acalabrutinib is better than ibrutinib in terms of efficacy and side effects. Overall survival is 81% with 40% complete remission. and 67% have been alive at 12 months. Zanubrutinib has got even less side effects and is even more effective at 87% overall survival and 69% at overall survival, complete remission, and progression-free survival of 22 months. People have been using lenalidomide along with rituximab with quite some success. These agents do carry some toxicity, particularly GI, like nausea, diarrhea, and hematological neutropenia, and mainly the agent mutation, particularly ibrutinib. If it is causing cardiovascular problems, we can switch it to acalabrutinib or zanubrutinib. Thank you very much. And I think I have finished in time, and I shall be quite happy to answer if you have any questions.
Thank you, Dr. Ghulam Nabi Kakipoto. Our last talk is by Dr. Farah Shah. She's a consultant hematologist at Withington Hospital in UK. She's the National Chair for Red Cell Disorders UK, and she's the current Medical Director in transfusion at NHS Blood and Transplant. So over to Dr. Farah Shah.
Hello, Assalamu alaikum. I just want to say thank you very much for inviting me to talk on blood transfusion in hematological malignancies. My name is Dr. Farah Shah. I'm a hematology consultant and medical director at NHS Blood and Transplant. So I'm going to be talking about when transfusion is important in hematological malignancies, and also I'll be covering red blood cells, platelets, granulocytes, and irradiation as part of the talk today. So hematological malignancies are a frequent cause for bone marrow failure, and multiple cell lineage production goes down, and hence patients end up needing either blood or platelets. And also the chemotherapy that we give patients will impact on their erythropoiesis and their production of platelets, and hence they'll need support there as well. It's also important so that we're managing the complications associated with bone marrow failure syndrome. So, for example, if people have a very low platelet count and need platelet transfusions because of myelodysplasia, and also to manage the risk of specific products that we give patients so that we're not causing harm to them. So I'm going to start off with red cells. Well, what should we be using from a red cell point of view? Well, packed cells are the ideal. They should be leukodepleted. We should be matching for ABO and RHD. In female patients of an age where they can conceive, we should be considering CEL-compatible products, and particularly for children, young girls who may successfully cure their malignancy and then go on to have families. We do need to be making sure that we're providing CEL-compatible blood. Blood should be CMV negative, but that is a question of debate, particularly if your red cells are leukodepleted, and you should consider irradiation in some circumstances, but all cells that are being given to patients with leukemia, for example, do not need to be irradiated. It's mainly in the transplant setting, or if patients have had exposure to drugs where they're at a high risk of developing TAG-VHD. So why is the hemoglobin threshold important? Well, historically, red cells have been utilized to obtain relatively high hemoglobins, for example, between 9 and 10 grams per deciliter. And the average use of red cells in patients with acute leukemia syndromes, for example, is between 30 and 60 units of blood. And that means that they can develop considerable iron overload. There's also some data to suggest that an increased red cell dependence is associated with a poorer clinical outcome. Each unit of blood gives 200 milligrams of iron, and patients very rarely get given iron chelation therapy until after bone marrow transplant. And they may actually go into a bone marrow transplant with considerable iron overload, and there is some evidence to suggest that heavily iron overloaded patients have got poorer outcomes during the transplant procedure. There's increasing data from other settings suggesting that a lower hemoglobin threshold, i.e. running between 7 and 8, is associated with an identical or even lower mortality in patients compared to a higher hemoglobin threshold. So this is just, I'm briefly going to run through this quick schema of what a bag of blood contains. About 200 mils of the unit of blood will contain red blood cells, and that's generally 5 times 10 to the 12 red cells in it. There'll be a small amount of leukocytes, and this depends on the efficiency of your leukocyte depletion. But generally in the UK, we aim for 1 times 10 to the 6 or lower for a white cell count. You'll have some residual plasma, which is a variable amount between 20 and 80 mils. And then you'll have the supernatant anticoagulant, which is about 100 mils. There are obviously risks associated with each of these individual layers, and we do need to be mindful of that. So for the red cells, we need to make sure that we're matching patients for ABO and RHD and consider matching for CAL. The leukocytes are HLA sensitizing, and if you do not have good leukodepletion, or you're matching with HLA identical or HLA similar products, then there's a risk of HLA sensitization. And then obviously there's a risk of an allergic reaction with the anticoagulants that we're using in the blood. And if you're giving a lot of blood, you may end up with a transfusion-associated circulatory overload. So reviewing the evidence base around the transfusion thresholds, the Cochrane Systematic Review, which was conducted in 2017, looked at 5 randomized controlled trials and 1 non-randomized study. Overall, the review had about 240 patients within it, and they actually analyzed the data from 3 randomized controlled trials and the non-randomized study, because the data from the other 2 randomized controlled trials not available. That data is actually still not available. 1 study included children having bone marrow transplant, and 3 studies included adult patients with acute leukemia or another hematological malignancy. And the restrictive thresholds were a hemoglobin from 70 to 90, and the liberal thresholds were a hemoglobin from 80 to 120. And what you really need to look at here is these graphs, which basically show whether the intervention favored the restrictive or the liberal. And what you can see here is that restrictive transfusion regime was beneficial in reducing the all-cause mortality. So that's definitely a positive benefit from restrictive transfusion. And then if you look at this plot here, this is looking at mortality due to chemotherapy. And again, this was slightly in favor of the restrictive regime, but pretty close to the middle, showing not necessarily a major benefit. And if you look here, this looks at patients with clinically significant bleeding. And what you can see here is that there's no difference between the restrictive and the liberal regime. And then we look at the life-threatening bleeding, and what you can see here is that there is a favor for liberal with the risk of life-threatening bleeding. But overall, there's not a huge amount of difference between outcomes for patients, and actually there is potentially considerable benefit from a restrictive regime with all-cause mortality. Now, myelodysplasia is, of course, a completely different condition, even though it is a hematological malignancy. And clearly, there are reasons why patients with myelodysplasia do need to be transfused. So Simon Stanworth published data on myelodysplasia patients who were either given a restrictive or a liberal regime. The liberal regime allowed them to have hemoglobins above 100, and the restrictive regime kept the hemoglobins much lower. This was a multi-center study conducted across the UK, Australia, and New Zealand. And essentially, the patients followed quite a tight algorithm with regard to how many units of blood they were going to be transfused based on their hemoglobins. And you can see here at the bottom of the performer there. And you can see that they did successfully manage to keep the patients above the thresholds that they had targeted for the liberal versus the restrictive regime. What I think is really important in myelodysplasia is the individual's quality of life. And what you can see is that the liberal regime was associated with a significant improvement in quality of life, looking at the EQ5D as well as the ORTEC-QLQ questionnaire, which focuses on physical, functioning, fatigue, dyspnea, and global health scores. So in myelodysplasia, having a liberal transfusion regime is probably beneficial in improving the patient's quality of life. I'm now going to talk a bit about platelets, and with platelet products, I think it's important to remember a couple of things. Pooled platelets are made up of 4 donors, which make up 1 pack, and apheresis is 1 donor. You must match for ABO and RH, particularly in females. And if you give females RH positive platelets when they're RH negative, you do need to give them some anti-D as well to reduce the risk of RHD immunization. A negative platelets are your universal platelets. And if you look at the use of prophylactic platelets, and this is another study conducted by Simon Stanworth, what you can see here is that prophylactic platelets are beneficial for people having chemotherapy and allogeneic stem cell transplantation, with a benefit in that population. But in patients with autologous stem cell transplantation, prophylactic platelets do not seem to show any significant difference. So you should use prophylactic transfusions for platelets in the high-risk group of patients, which is allogeneic stem cell transplant and intensive chemo, but you probably could get away with not using prophylactic platelets in people with autologous stem cell transplantation. The BCSH guidelines look at prophylactic platelets where the bone marrow failure is reversible, and they give clear recommendations that you should be trying to keep the platelet count above 10 × 10⁹ in patients who are having intensive chemotherapy or undergoing a transplant, allogeneic stem cell transplant. You should only use 1 dose of adult platelets at a time, and you should consider not giving prophylactic platelet transfusions to well patients with no evidence of bleeding who are having an autologous transplant. And consider increasing the threshold of prophylactic platelets to between 10 and 20 for patients who are judged to have additional risk factors for bleeding, but this is an individualized decision. In patients who have got non-reversible bone marrow failure, the general rule should be no prophylactic platelet strategy for people who are asymptomatic, and this includes people on low-dose chemotherapy regimes. You should give prophylactic platelets to people with chronic bone marrow failure who are receiving intensive chemotherapy, because quite often you're doing that with a curative, potentially curative intent. And you should manage patients with chronic bleeding with platelet transfusions and consider a prophylactic strategy, for example, twice a week for their platelet transfusions. With regards prior to procedures, do not give platelets routinely for bone marrow aspirates or trophine biopsies, or if you're putting in a PICC line, or if you're removing a tunneled line, or for cataract surgery. But you should give prophylactic platelets in the following settings. So if you're going to put in a central venous catheter line, both tunneled or non-tunneled, then you should keep the platelet count above 20, and this is using ultrasound guided techniques. If you're doing a lumbar puncture, the platelet count should be above 40. If you're inserting or removing an epidural catheter, then you should have the platelet count above 80. Major surgery, the platelet count should be above 50. And neurosurgery and ophthalmic surgery should be aiming for a platelet count of above 100. And if you're going to do a liver biopsy, the aim is to do the platelet count above 50, or consider a transjugular biopsy if you can't get the platelets up above that level. There has been obviously a real drive to use tranexamic acid to reduce the risk of bleeding in patients. And there was a study published in Blood which looked at prophylactic tranexamic acid in patients with hematological malignancy. And what you can see here is that there is no difference between the placebo arm and the tranexamic arm between bleeding of any grade or either on the primary or the secondary endpoints. And then finally, I'm going to talk a little bit about granulocytes, because I do think that granulocytes are quite an interesting topic at the moment. So granulocytes can have benefits, as in that you give patients active neutrophils when they're severely septic, and this may buy them time to recover from their chemotherapy and generate their own neutrophils to help them overcome infection. However, it is associated with an increased risk of HLA sensitization, and you may get engraftment and transfusion-associated graft-versus-host disease, which is actually fatal. So a number of studies have been published looking at granulocytes. Now, the general method for manufacturing granulocytes is by giving the donor GCSF and steroid stimulation and doing an apheresis collection, and then you irradiate the collection and then administer it to the patient. The Scandinavian group that I'm showing here, they gave 30 patients granulocyte infusions, mostly daily for 3 days. And they showed that there was a median time to resolution of febrile neutropenia of about 14 days. And there was quite a broad range of different bacterial infections for where they used it. And the primary reason or the indication for using granulocyte transfusions was pneumonia, generally resistant to treatment, and or neutropenic enterocolitis or acute abdomen. Quite a few of their patients actually also had fungal infections as part of that pneumonic infection. So a review has been conducted into the use of granulocytes, and this looks at case studies where patients with fungal infections were given granulocytes with some good effect. And then if you look here at the larger studies where they looked at granulocytes, you can see quite a stable dose of about 4 × 10⁻⁻10 neutrophils per unit of administered product. And what you can see here is that patients did get, about half of the patients or more got some degree of recovery from that infection. So historically, NHS Blood and Transplant has supplied granulocytes. We used to do it as apheresis, similar to what's been shown in the other studies that I've just shown. But more recently, we now do granulocytes as a pooled component, which is made from standard red cell donations that we're collecting as part of standard blood donation. So what we generally supply is between 1 and 3 bags in the adult setting. They're made up of buffy coats that are then pooled together. They're generally available about 4 to 5 days in the week, and we match them for blood group ABO and D compatible. So they have to be immediate cross-match compatible. And we irradiate the products, and CMV negative products are given to CMV negative recipients. And the Progress registry or database is the largest registry, in fact, in the world. And we presented at the American Society of Haematology. The presentation was led by Susie Morton, who is our granulocyte lead. And she presented data comparing NHSVT pooled granulocytes in comparison to European registry, where they compared both apheresis and pooled products. And the indications for these granulocyte infusions were refractory infection or bacterial or fungal infection. What you can see here is that the mean dose for the NHSVT product was actually a little bit lower in comparison to the apheresis or the pooled packs. However, the important thing here, I think, to take home is that death within 3 months of the last transfusion was virtually identical across all of the 3 different products that were being used. And finally, just a quick couple of words on irradiation to prevent TA-GVHD. The guidelines are very clear in that you should use gamma or X-ray irradiation for irradiation. The effective dose is 25 gray, and no part of the pack should be exposed to more than 50 gray. And there's insufficient evidence to recommend leukocyte depletion alone to prevent TA-GVHD in susceptible patients. And red cells can be irradiated any day up to day 14 after collection and then stored for another 14 days. all granulocytes should be irradiated immediately prior to use and transfused with minimal delay. And all transfusion of cellular components and fresh plasma for first or second degree relatives should be irradiated, even if the patient is immunocompetent. And all HLA selected products should also be irradiated. So I just want to say thank you very much for inviting me to speak at this meeting. I'm very happy to answer questions at the end of the meeting. Thank you.
Thank you very much. That concludes our 4 talks. Now we'll open panel discussion. We have our panelists, Dr. Firas Al-Kaisi, Dr. Farah Shah, and Dr. Ghulam Nabi Kakipoto online. And we have Dr. Nida here with us physically. So first of all, I'll take the liberty to thank all the panelists. In the UK, I think it's early in the morning, so they must be up very early, Dr. Nabi and Dr. Ghulam Nabi and Dr. Firas. I'll start with Dr. Farah Shah because she's herself moderating a session, a conference in Malaysia, but she's thankfully taken time to come online with us. So Dr. Farah, I will ask you a question. Here in Pakistan, we have directed donations where the patients are getting chemotherapy, leukemia, bone marrow transplant. We do not have non-directed donations. So, and while in UK, the transfusion associated GVHD was not unheard of, or it was a thing of the past or only in books. So what is your feeling about that here when we're using the directed donations?
So directed donations are definitely not a good thing to do. Now, I look after thalassemia patients, and this is obviously clearly a problem within the thalassemia population as well. What we normally would recommend is that rather than doing a directed donation, you do a replacement donation. So you ask a relative to donate, and it replaces blood for someone else so that it's not the HLA matching doesn't actually influence what's going to happen next for the patient. So many countries, low middle income countries globally, use replacement donations. And I think that using a replacement donation rather than a directed donation is probably the safest thing that you can do. Remember that many of these patients, particularly in the malignant setting, are likely to go on for transplantation. And you really do not want to get HLA sensitization in those patients.
Thank you. No.
Okay, so I've got a question to Dr. Firas Al-Kaisi. Dr. Firas Al-Kaisi, are you with us?
Yes, I hope you can hear me all right.
Yeah, we can hear you. We can hear you. So an excellent talk, Dr. Firas. My question was that as we've got emerging data for CAR T cells in the context of multiple myeloma, how do you see it will be placed in the patient who's relapsing in multiple myeloma, as you've got a lot of other options available in due course as well?
Thank you. That's a very interesting question. The problem with CAR T cells and CAR T trials is that the process of manufacturing CAR T cells takes quite a lot of time. And there are probably 2 types of relapsing patients. There are the patients who are relapsing very quickly, and you have to give them some sort of treatment before they're able to have the CAR T cells. And there are those patients who are relatively early on during their lines of treatment, and they still have time to, you can apheresis them and then give them some holding measure treatment of some sort, and then you can infuse the CAR T cells back to them. And I think this second group of patients are probably the ones that are going to benefit most from CAR T cells. So patients early on during the relapse process, perhaps at the moment, because of the challenges in the manufacturing and the time it takes to get the CAR T cells to patients. The other interesting thing about, I mean, that also reflects the results from the clinical trials. I mean, the sort of 30-month progression-free survival of those patients who had the cilta-cel, they were heavily pretreated, but I can't imagine that those patients were relapsing very quickly to the point that you had to give them some sort of treatment before they get the CAR T cell. So that might bias the data to a certain degree. The interesting thing about all immunotherapies is that they do rely one way or the other on a strong immune system, relatively non-exhausted immune system, and perhaps this is better seen in patients before later lines of treatment.
Thank you.
Thank you very much, Dr. Ghulam Nabi. There's a question for you. I hope you can hear me.
I can hear you clearly. Yeah. Can you hear me?
Yes, it's perfect. So just wanted to ask you regarding pre-treatment evaluation of mantle cell lymphoma. So what is your criteria for screening with endoscopies in your patients? So do you screen only early stage disease? You screen all of them? How do you go ahead with that? And secondly, regarding CSF evaluation, you would do it only for blastoid morphology, high Ki-67 or high MIPI. So just wanted your advice on that.
We wouldn't do the upfront endoscopies unless there's suspicion or there are symptoms in the lung or in the GI. And also the baseline CT scan would guide us as well, that whether there's any involvement in any of the viscera. So that would be the case, but not in people who don't have any symptoms. And the standard would be for any other lymphoma, like baseline blood investigations and the CT scan and some situation the PET scan. Sorry, the next, what was the second question? CSF. At the relapse, if or people who have got high blastoid, who have got a blastoid morphology or pleomorphic morphology, we would only do CSF if they have got symptoms. And of course, if they have symptoms, we'll do the MRI scan, and if there's suspicion of the involvement, then we'll do the CSF. Otherwise, not routinely, no.
So feel free to ask questions from the audience. If you have any questions, you can take the mic. Yes,
hear
Dr.
me?
Waqas.
So I have a question for Dr. Neda about CML. So great talk. So you mentioned about TFR, and obviously in our part of the world, it's a very attractive option. But the limitation is the strict monitoring that follows after TFR. So my question is that, do we really need to do that sort of monthly PCR testing? It's not a condition that's going to, suddenly go into blast crisis. So can we modify it in our part of the world so that we can use it in our practice?
Thank you very much, Dr. Waqas. Very relevant and practical question in our scenario. Basically, the problem is that we read the foreign guidelines, but things are different in our part of the world, and which is very sensible. What we practically do at NIBD, that we do it at 3 months, because practically it's not possible for the patients. We've started TFR in some of our patients, and we do it every 3 months. So this is what we do in our practice, and I think which is quite relevant in our part of the world. And if the patient doesn't have, any financial issues, that is also practical. But majority of the patients that present to us, practically it's not possible to do it every month.
There's a question for Dr. Firas. We were just looking at the treatment algorithm of newly diagnosed multiple myeloma, and the upfront treatment that we saw that you highlighted in one of the slide was either DARA VTD or it was VTD alone. Just wanted to ask you that it is because lenalidomide is not approved, number one. Number two, we know that there is no head-to-head randomized trial comparing VTD to RVD. So is there anecdotal evidence-based data from UK which actually support upfront thalidomide as immunomodulatory agent?
Yeah, thank you very much. That's an excellent question. I wonder sometimes why, I know the answer, but to why we can't use VRD upfront is because of the way those drugs are licensed in the UK. VTD thalidomide was very cheap, and therefore it was the preferred drug in the combination to start with. And but as you said, there is no evidence yet. There are direct comparison between DAR-VRD and DAR-VTD, but we know that lenalidomide is more tolerated, and thalidomide is certainly associated with more side effects. The use of lenalidomide up front in this setting is certainly preferred now that lenalidomide has been off patent, so we don't have to. In the UK, they have to pay a lot of money to get the lenalidomide now. It seems that the logical option is to use DAR-VRD as first line. However, this hasn't happened yet because of the way licensing has worked. In fact, I think we pay a little bit more for thalidomide than the lenalidomide currently, which is a little bit counterintuitive. So in answer to your question, I think DAR-VRD should be used as first-line treatment, even though that we don't have evidence to support that lenalidomide may be better in this setting, but it's certainly more tolerable.
Are there any more questions from the audience? Yeah, another question.
So, Dr. Neda, this question for you regarding upfront treatment of chronic myeloid leukemia patients. So, how do you choose upfront treatment, upfront TKI in a newly diagnosed chronic myeloid leukemia patient? So, do you choose them on the basis of risk scoring system? Because we know that now the first generation TKIs are available as generic biosimilars in Pakistan as well. And there is limited availability of second generation as well.
Well, it has to be an individualized approach, basically, that we follow. But as I presented in my presentation as well, and this is my practical experience as well, we have majority of the patients who are young aged, 30s, 40s, 50s. In those patients, if there are no availability issues, if the patient is fine, there's an access program availability, we do prefer nilotinib. And surprisingly, in our part of the world, as we read the guidelines in UK, they usually don't prefer nilotinib because of diabetes and all these things. But practically, what I feel, our patients practically don't have any issues with nilotinib. But yes, if there's a patient who is 70 years, 60 years, affordability issues, availability issues, that is the cohort where we do start with the first generation TKI, that is imatinib. So for the young patients, we do prefer nilotinib, and the majority of our patients are on nilotinib.
Dr. Farah, I have another question. Amongst all these malignant hematology questions, I think it's very useful to hear from you as well as far as transfusions are concerned. So platelets, we have another dilemma with platelet transfusions here. We tend to give single units if we don't have apheresed units. And then there is always a question, pediatric units, 4 equivalent to 1 or 6 or weight-based. What is your view on that again, in a restricted environment situation like us, as you deal with similar, as you mentioned, in Palestinian kids, etc.?
That's actually a really good question, because we have in the UK continuously, even though we're very well resourced, we do end up in problems where the platelet supply can be impacted. In particular, A-neg platelets, which is our universal platelets, can be challenged. So one of the things that we've done when we had the UK Amber Alert around blood shortages was that we did some work on split dose platelets. So using normally our adult platelet pack is made up of 4 donations. And we have done some work on split dose platelets, and split dose platelets basically are either a split single apheresis collection, or it's a low dose of the pooled product. They certainly seem to do the job. I think that's the important thing here, is that, you know, are they going to reduce the risk of your patients having a bleed because of a low platelet count? And they certainly, even though the actual dose is less, in the short term, you can use smaller packs in essence. So I think it's okay, but overall what you end up doing is you end up giving platelets more frequently, because you're not giving a big dose up front. So I think that's where the challenge is. You'll end up using daily platelets rather than every other day, because you're giving a lesser dose at the beginning.
Thank you. So I've got one more question for Dr. Nida. So Dr. Nida, in the last few years, you've got quite a few biosimilars have coming up for imatinib. So what's your experience in the context of their efficacy, any more different side effects and so on?
Well, very honest, during the last 1 year, 2 year, there were availability issues with the access programs, and we didn't had an option rather than, you know, switching the patient to those, rather than, you know, giving them no treatment for that time. So what I felt that they were quite tolerable. I mean, their safety profile and efficacy profile was quite comparable, I would say. So that was the time that we had a comparative, you know, idea. So I think they are feasible. Yeah.
If we have no more questions, we can conclude our session. I will once again like to thank all the speakers and our panelists for joining us online at an odd time. And if nobody has any questions, we'll conclude it here. Thank you very much.
Thank you very much for having us.
Thank you.